and already kind of paving the way for the panel discussion. Thanks a lot, Rob. So next up, we'll have Dr. Torben Ott. Torben is a relatively new group leader in Berlin, and I'm happy to welcome you. And Torben will speak about striatal mechanisms for hallucination-like perception in rodents. So.
Okay, yeah, thanks a lot, Prateep, for inviting me and putting together the symposium. And as part of our mission to better understand how psychedelics work, we focus on hallucinations and hallucination-like perceptions. And these are processes that we can study both in humans and in rodents. So basically, I want to show you that we can build up an argument that mice can hallucinate, or in a sort of super small version, like a mini hallucination, but I'll walk you through that. So let me see this thing. Aha, good. So in this recent book, Anil Seth has said, and this is quoted now kind of a lot, that we can view perception as a controlled hallucination. And what is meant by that is that we don't perceive our external environment exactly as it is, but that our percept is strongly influenced by our prior expectations. And here's an example that I borrowed from a review from Phil Corlett, where we're looking at a scene here of a man from behind holding a device to the head, which looks something like a hairdryer. Now, this might be a very common scene in the context of, say, a bathroom, and your prior expectation of seeing a hairdryer is fairly reasonably high. It's in accord with the input from the sensory system, and your percept might pan out accordingly. Now imagine a different scene. You're outside in the night, in a big city, in a dark alley, and you see something like this. Now your prior expectation might be quite different. You might not expect to see a hairdryer, right? And you might see a gun, for example. So what I'm arguing here is that we can view hallucinations as an extreme version of this process of integrating sensory information and prior expectations. And if we take this seriously, this means that we can study the neural mechanisms of hallucinogens by studying normal and aberrant perception. And this gives us a way into the neural basis for psychedelics. And even then, even when taking this seriously, it's not that easy. Why? Because perception and hallucination are still subjective. And these are subjective experiences, so how can we access them, especially in animal models? And our focus here is to study the computational processes that describe perception, perceptual inference, and this links candidate neural circuits with both the subjective content of perception and with observable behavior that results from these processes. And then we can see how we can translate now from humans to animals, because we can study the same information processes that give rise to similar analogous behaviors and identify neural circuits, even if we don't have access to the subjective content of perception. So concretely, I'll present a study in which we developed a behavioral task to model what we call hallucination-like perceptions in rodents. And this is to also emphasize that we're talking here about a reductionist, reduced version of hallucinations. We then looked into neural circuit mechanisms, concretely into striatal dopamine. Now, I'd like to highlight Katharina Schmack here. She spearheaded this study. She runs now a lab at the Crick Institute in London, and this work was conducted in Adam Capit's lab in Washington University in St. Louis. Now, again, going back to the idea of perception and Bayesian inference. Here, we will characterize a hallucination as a false percept, a percept in the absence of evidence, perceived with high confidence. The percept looks or feels real in some way, even if you know it isn't real. And we then devised a behavioral task that combines classic ideas from psychophysics with a novel component of a confidence report to study this perceptual process. So here we use mice trained in this task. The mice are walking around in this little behavior chamber, and there is a wide background noise that is played back almost at all times. And then sometimes we embed a faint signal, a frequency stimulus in this background noise. The mice perform a series of decisions, They start what we call a trial, an individual decision process, by poking into the center poke. And here we're looking at a signal trial where now the poking triggers the playback of this faint signal. And then the mice can make one of two choices. It can go left or it can go right. And here right means that it heard a signal, which is the correct answer because this was a signal trial, and this will lead to a water reward. And in the signal detection theory field, this is called a hit trial. Now, if the mouse goes to the left side, that indicates that it did not hear a signal. This is a mistrial, it will not be rewarded. Now we randomly interleave no signal trials. Now here, the contingencies are the opposite. Now here the mouse has to go to the left side, indicating that it did not hear a signal, which is here is correct, which will also lead to a water reward. While if it goes to the right side, indicating that it heard a signal, this is incorrect, will not lead to a water reward, and this is called a false alarm, and these will become particularly important in the subsequent analyses. Now, in the second portion of this task, we measure behaviorally confidence. So to measure this, the idea is here, the trick is that we randomly delay reward delivery for up to 5 seconds. And nothing tells the mouse whether it's going to get a reward or not. It has to rely on its own estimate of being correct. And so in these incorrect trials, false alarm and mistrials, and a subset of correct trials, 5% of probe trials, there will never be a reward. So the mouse commits to a choice, it anticipates a reward, it waits until it has to at some point decide when to stop waiting, leave in order to restart a trial. And this waiting time we consider an investment, and we will then analyze whether this reflects confidence in this task. Then to reiterate, here we operationalize now what we call hallucination-like perception, HALIP, as false alarms. These incorrect choices heard a signal even though there was none, perceived with high confidence, meaning the mice invested a long amount of time. Now let's first look at the choice behavior of the mice. So here we're looking at the percentage of signal choices as a function of the signal-to-noise ratio. That's the loudness of the signal that was embedded in the noise. And we see if the signal was loud, the mice always report signal choice. Yeah, that makes sense. And then if the signal is faint, they sometimes report signal, no signal. And now importantly, here are all the trials, all of the no signal trials. And still in about 20% of cases, the mice report hearing a signal. Now, this idea is not particularly novel, but what has been very difficult is to interpret these error trials. Because there might be a number of reasons for those. It could be just at some point that don't pay attention or they're not motivated, whatever that exactly means. So how can we know whether a false alarm is related to the perceptual system? And here confidence again comes into play, where we now use a model for confidence, where we define confidence as the probability of being correct given the amount of evidence that you have at your disposal, which here is your percept. And this model makes a number of quite specific predictions that we can test in the behavioral data. So this is now a model here where the amount of confidence going higher, predicts the accuracy in the task, of course, because that's how it's defined. But also confidence increases with the signal-to-noise ratio in correct trials, but decreases in error trials. Or in other words, the same sensory stimulus for the same sensory stimulus, confidence tells you whether we're correct or incorrect. Also, if we look at high confidence versus low confidence trials, we see that in high confidence trials, we have a steeper psychometric curve, again showing us that these trials tend to be more correct. Now, when we look at the data of an example mouse here, we see that the data follow these quite specific predictions, and this allows us to argue that time investment serves as an appropriate behavioral readout for confidence. So then we have both now false alarms and high confidence. So let's look at common manipulations that have been used also in the human literature to induce these simple kinds of hallucinations or hallucination-like percepts. And first here, we're looking at strong signal expectations. So we're inducing a strong expectation of a signal, which in humans is associated with perceiving, having a wrong percept. And so now we have stretches of trials where we show 70% of signals versus 30% of signals, and it shifts the psychometric curve exactly as we would expect. Namely, we see an increase in false alarms when we have a high signal proportion, but also an increase in the amount of time the animals invest, meaning an increase in their confidence report. Then second, we also injected a cohort of mice with ketamine. And again, we see a small leftward shift and, or at least an increase in these false alarms and amount of time investment here in this task. Now, we also ran a human version of this task where we used the exact same stimulus, the same white noise, the same signal, and similar signal to noise ratios. In this human version, we had online participants wearing headphones, and they indicated whether they heard a signal or not with a button press, and reported their confidence on a scale. In humans, it's a bit easier, so we don't need to do this trick with the time investment to get a readout of their confidence. Again, here's a psychometric curve of human participants. Very high, always correct, when the signal noise ratio is high. Again, we have in humans, around 10 to 12% typically of false alarms. And then we added psychiatric phenotyping here with questionnaires to these human participants. And specifically, we used the CAP score to quantify hallucination self-report. So these include questions like, do you hear sometimes voices? And even though this was a general cohort, we see a quite broad distribution of these CAP scores. So we asked whether this would relate or be correlated with the performance in this task, namely with having false alarms with high confidence. So here we see the CAP score related to false alarms and the CAP score related to the confidence in false alarms. And here we saw a somewhat small, but still a correlation in this exploratory study. But was even more interesting that we also added other dimensions here, depression, anxiety, and so on. And this was the only one that showed this kind of correlation. So, before we go to the second part, to briefly summarize, we have this behavioral task that we can run in animals and in humans. And we have done at least a couple of validations for this task, where we now argue that we can quantify hallucination-like perception. Now, to start digging into the neural circuits, there has been a long-standing hypothesis also for, in the schizophrenia research, that striatal dopamine could play a role in psychosis. So, for example, there's increased turnover of dopamine in the striatum. And this was one of the motivations here to look first into striatal dopamine. So we here measured the relative concentrations of dopamine in the striatum using dopamine sensors similar to the serotonin sensors that we've seen before. So these are modified dopamine receptors that become fluorescent when dopamine binds to them, and it allows to measure the concentration in vivo during the behavior. We focused on two subregions of the striatum, the ventral striatum overlapping with the nucleus accumbens and classically associated with reward processing, and the tail of the striatum, which at least some animal studies have shown it could play a role more in sensory processing or novelty. And so here we implant a fiber and we express a sensor and then we measure fluorescence. Now here we see this fluorescence signal, the proxy for our dopamine concentrations across time, and here aligned to the stimulus onset in the task. And we see somewhat similar-ish responses, meaning there is a higher the amount of fluorescence here after stimulus onset is correlated with the signal-to-noise ratio. But what we also observed is that even before the stimulus comes up, there was a fair amount of trial-by-trial variability in the amount of fluorescence. And this we see here. So this is now the baseline fluorescence just before the stimulus comes up. And here we see a difference between the false alarm fluorescence levels and the correct rejection fluorescence levels. So these are all no signal trials, but we see a higher fluorescence whenever later on the mouse would report a signal in both areas. And even more so, we also saw a correlation between the strength of the signal and how often the mice would respond with a high time investment false alarm. Now we saw this in both of these areas, and to further interpret what these signals could mean, we have to briefly take a step back and look at a computational model. Like this is a fairly standard model that would explain this perceptual inference process. And briefly, the idea is that your percept as I said in the very beginning, is a combination of both a prior expectation, that's often called a prior, here denoted with mu pi, and the sensory evidence that you have, sometimes called likelihood, if we're using full distributions. These are then combined using Bayes' theorem to form the posterior distribution, and your percept is sampled from this posterior. Now, your percept then determines the choice. You heard something or didn't hear something for a detection task, and also the amount of confidence that you have. And then eventually you receive some feedback, whether you made a correct choice or not. And this feedback then is scaled by the amount of confidence to form a prediction error, and this prediction error updates the signal prior, the amount of expectation that you have. So this model, naturally, because it's designed for this kind of perceptual inference process, reproduces the psychometric curve and these confidence-specific signatures. But now, importantly, there's two ways in the model to obtain something that looks like a hallucination-like percept, or specifically an increase in these false alarms. And one way is by having, prior to hearing a stimulus, having a higher prior reward expectation. And that corresponds in the model to a high absolute value of your prior mu pi. This would lead to false alarms, more false alarms, but also to more misses, which actually was not something we saw in the behavioral data. The other way is having an increased signal expectation. This increases your false alarms, but also your hit trials, which is more in line with what we saw in the behavioral data. Now, when we revisit our dopamine data from the two strial subregions, what we saw is that the predictions from the model for reward expectation versus signal expectations, there are like two key predictions here. One is that the amount of reward expectation, the absolute value of the prior, is correlated with the probability of being correct, but not with the probability of making a signal choice. And vice versa for signal expectation, where it's a bit more intuitive, perhaps, that the amount of signal expectation correlates with you making a signal choice. And when we look at the data, what we saw is that in ventral striatum, the data, at least qualitatively, resembled more the reward expectation process versus the tail of the striatum, fluorescence, dopamine levels, resembled more the signal expectation data. So this means, at least here in this study, the tail of the striatum is a particularly strong candidate to signal the prior of a signal. Now, in the final set of experiments, we increased dopamine concentrations in the tail of the striatum using optogenetics, expressing light-sensitive channels in dopamine neurons, dopamine-releasing neurons, and this increased both the false alarm rate and the time investment. This effect could be rescued with haloperidol, and both for the false alarm rate and the time investment rate. And this effect actually has been recently reproduced by a group at the University of Chicago, just published a month ago, which for us is great because, you know, this is one study and not that many animals. So it looks like this dopamine-dependent effect in the striatum is something that could play a big role in these kinds of behaviors. So to conclude, at the end of my talk, we saw that we have this behavioral task to quantify hallucination-like perceptions as a potential model for hallucinations. We can run this in humans and animals. It seems strial dopamine plays an important role in these hallucination-like percepts. This data is most in line with dopamine in the tail of the striatum signaling the amount of signal expectation. So a little mock circuit, which is mostly, you know, hypothesis at this stage, could look like that here in the tail of the striatum, increased dopamine somehow increases whatever signals come in that would convey the expectation. Now, ongoing work in the lab here. So I started my lab last year in Berlin. So unfortunately, just short of being able to share data, I think hopefully next time or so, we are looking at whether we can expand this model into serotonergic hallucinogens such as psychedelics, and then specifically look at how serotonin and serotonin receptors in different brain areas could be related to these hallucination-like percepts in rodents. And with that, I want to thank my lab here in Berlin. There's two people here working on these projects, Eric and Daria. if you want to learn more about these behaviors. And again, thanks to my collaborators, Karina and Adam, and thank you guys again for inviting me and being here.
So we have time for 2 questions from the audience. Yeah.
Yeah, so Matthew also started with Emil Seth, right? So we're using they're similar frameworks for perception, for sure. And it would be very interesting to apply his theory about dendritic coupling in this context, for sure. There is, I think, a vast array now of experiments that we can and want to do. One of the first ones, I think, would be looking into a number of different areas across the cortical layers and just identifying which areas are even good candidates here, right? And I do think this experiment is something that we eventually should do. Realistically, I think it's going to take time, and we haven't done it yet.
That is not really what we are more talking about with the psychedelics, for example. Do you think it's going to go also into that pathway in terms of the neuroscience?
Yeah, so this study was motivated also from exploring new models for psychosis. And here, dopamine has been implicated for a long, long time. Just early antipsychotics acting on the dopamine system and so on and so forth. Likely, I think there will be multiple circuits involved. So there will be multiple ways of pushing around the perceptual system and multiple ways of inducing something like hallucinations or full-blown hallucinations. And there are convergence points. I mean, for example, in the animal literature, it is fairly well established that ketamine increases striatal dopamine levels. Just to name one of them. And then when you think about the circuits and, for example, you combine sensory information with prior expectations, this is a process that likely also happens in many places. When you think about hierarchical loops in cortex and all of these ideas in predictive processing, and that implies that there are multiple locations or multiple circuits where you could induce potentially different kinds of hallucinations, who knows? Yeah, so there's many ways I think how these could converge.
I have one question for you, Tom. So I'm really curious, one day if we could test this Carhart-Harris hypothesis of rebus, because this theory has been put out there, relaxed belief under psychedelics, but I think there is a complete lack of mechanistic understanding of such theories which come from human studies.
Yeah, please, anyone correct me also if I'm wrong, that there is basically no evidence for the rebus model, but it is here at this stage, it's a very interesting theory, of course, and it lives in a similar framework. So these Bayesian inference perceptual models, they come out of the even more general models about predictive processing, or all the way up to, for instance, free energy principle. And I think what we have to do is we have to fill them with concrete, specific situations, specific kinds of behavioral tasks, specific kinds of perceptual processes, and that are sort of special cases of these bigger frameworks. And currently, our data indicates more that dopamine is here correlated with an increase, like more dopamine leads to hallucinations because of an increase in your signal prior, which sounds sort of like the opposite of the relaxed expectations, which is a reduce prior in the rebus model. But that's not necessarily yet a contradiction because, but that becomes a bit technical possibly, but because he's talking about these landscapes of the different priors that you have, and the switching between those within this landscape is easier or happens. You need less energy to switch between those different states if you're under psychedelics, right? And here we're looking at a fairly simple situation, right, where we have one signal. So that's one of the reasons why I think at the moment we cannot fully argue for one or the other, and they might not be mutually exclusive in the end.
Thank you very much, Torben, once again. So we are in the middle of this symposium, and it's time now to go to more human side of things. So with this, I invite Professor Kim Kuypers from Maastricht, and she will talk about microdosing psychedelics. Where are we and where to go from here? Welcome.
Thank you so much, Prateep, for the invitation and the introduction. Indeed, we're now moving to the human model, leaving the mouse model, the animal model. Still waiting to get my slides here. So this is the beautiful building where I work in the Netherlands, in Maastricht. And as I said, I'm going to talk about microdosing psychedelics. I will start off with a definition so that we are all on the same page. What is microdosing? It is taking 1/10 to 1/20 of a regular dose. Question is, what is a regular dose? You can base that off research, doses that are used in research. So that would be between 10 and 20 micrograms of LSD, between 1 and 3 or even 5 milligrams of psilocybin or another psychedelic. People are also microdosing with ayahuasca, for example. You take the low dose repeatedly for a period, and it is with the intention to improve certain aspects of life without disrupting any other processes. And it's intended to have, you don't want to have the hallucinogenic effects. So how do you do that? If you want to use LSD, you can buy a blotter and clip a piece off and dilute it in water and then take it. Or you can also, let's see whether I can manage this pointer. You can also buy it online, the truffles, in these packages or like this. And then it's the question, how do you take it? And one schedule is this. It's the Fetterman schedule. You take it on one day. It's the day that you experience the acute effects. You leave on the second day, you experience the subacute effects. And then on the third day, you don't feel anything anymore. That is the hypothesis. And then you proceed on taking another dose. Why the schedule? Fetterman introduced it as a research protocol to investigate for yourself what microdosing does to you. But I looked on the internet, and there are also several other research or other microdosing protocols, and we also learned that from our survey research, where people state that they come up with their own schedule. But I thought this was very interesting because it's running before science. They say how to choose your microdosing protocol. It starts with, are you a beginner? And then you can follow this. Yes, I'm a beginner. And then the question is, do you suffer from a psychiatric condition? If it's yes, then they state use it every other day. If you don't have a medical condition, so you can use the Fetterman protocol, the one I suggested. If you're not a beginner, then it's the question what your main goal is. Is it to do one of these things? Yes, then use the Stamets protocol that is stated here. Otherwise, use the Fetterman protocol or an intuitive protocol or 2 fixed days. So what is the Stamets protocol about? It's taking 4 days in a row and then leaving 3 days without dosing. And you also stack it. You use something else together with it. You can combine it with lion's mane or niacin. Niacin, which is used as active, as placebo in psilocybin studies. Just kidding. So my title was, where are we and where are we going to? I want to first start by telling you where we are in Maastricht. And I think our journey started, 6 years ago, when we started off with, we wanted to do a microdosing study, and microdosing is, like I told you, giving repeated doses to people. But then we had the question, what is a microdose? We do not exactly know what it is. So we said we will start off with a dose finding study, a controlled lab study. But in parallel, we also started survey studies. And the first survey study was about, we asked people, why do you microdose and do you use it as self-medication? What came out of this study was that people have different motivations to microdose. It's to enhance concentration, creativity, productivity, but also to help out with mental health conditions. And in this survey, we also showed that we asked them, when you microdose, can you compare the efficacy with when you use conventional medication or a regular psychedelic dose? And we showed that people with ADHD find it more efficient or better to treat their condition, to take microdosing compared to conventional medication. So that put us on the track of ADHD. And we're now also doing a controlled lab study together with Matthias Lichty's group in Basel. So we're doing a controlled study in ADHD patients. What did we do more? So we did the dose finding study, and we showed that we gave people 0 micrograms of LSD, 5, 10, and 20. And we showed that with 20, some people really experience things, so that's not non-hallucinogenic anymore. But they also experienced positive effects, increased mood, positive mood, but sometimes also increased anxiety, increased attention, which is also very good in the context of ADHD. So then we continued with the repeated dosing study that we have now concluded. We gave participants 4 doses with, I think, 2 days in between, 15 micrograms of LSD. I'm not going to discuss these data today. We're still analyzing them. We also conducted the EEG, and I can tell you we saw something in the EEG, so that's good. And we also saw it 4 days after they stopped microdosing. And then, like I told you, we have this, then now I clicked the wrong button. I wanted to show you this. No, never mind. So what I'm going to do now is focus on our, I called it a survey study, but I will explain what it means, a survey study. I will focus on this one, and then shortly on this one. So, this survey study, what does it entail? We designed a prospective naturalistic study, and this is the advertisement. It's in Dutch. I knew it. You probably cannot read it, but this is the way we attracted people. So we asked people, do you think you have ADHD? Are you diagnosed, or do you have symptoms? And do you have the intention to start microdosing with psychedelics? And then they could enter the study. And this was the study design. So we had a baseline measure before they started microdosing. We assessed them at 2 weeks and at 4 weeks in the microdosing process. What did we assess? Multiple things. We assessed emotion regulation and empathy. And there should be something else. It doesn't matter. We also assessed mindfulness and personality. I will not. And then we assessed ADHD symptoms, well-being, and time perception. So you can go and have a look at the poster of Eileen Haayen. It's a PhD student who's working on this project, and she presents these data on a poster. I will not discuss the mindfulness and personality data, but I can tell you that after 4 weeks of microdosing, they had changes in their trait mindfulness, and also their personality. So for example, here, neuroticism decreased. So we're going to focus on this part. So here you can see the flow chart of the participants, and here you can see also that it was a very difficult process, like it's always when you do naturalistic studies. You start off with a bunch of interested, highly motivated people. And then you end up with, so we started off with 365, I think, 56, and we ended with 47. Why is that? Yeah, because people lose interest or because of other reasons. We also had to include some of the people here because they had incomplete responses at baseline or for other reasons. What we did, as I told you, not everybody had a diagnosis of ADHD, and that was really the intention because we're targeting adults, not everybody is diagnosed, and people do experience symptoms. So that's why we used the CARS, the Connors Adult ADHD rating scale, to define their symptoms, and you have a cutoff of 65, which states if you are above this cutoff or on this cutoff, you have elevated symptoms of ADHD. So here I show you the group. This is at baseline, at 2 weeks, and at 4 weeks. You see that it were mostly females. Yeah, it's half-half almost. Most of the people came from Europe. They had a high education level. They did mostly computer or office work. And then here you can see how many people had a diagnosis. This is not solely ADHD. This is shown here. So it was a group that you do not see, I think, in controlled clinical trials, because there you really go for the people who have ADHD, but that's not the way it is. People have comorbidities, as you can see here. People had depression, anxiety disorders, PTSD, a lot. We also asked them which psychedelic they used. We used a diary to assess that. Not everybody filled out a diary, but those who did, here you can see that most of them used psilocybin, either mushrooms or truffles, followed by novel lysergium. So the novel, I cannot pronounce it. And then followed by LSD and ayahuasca. That was only one person who used ayahuasca. I think very interesting here, also something that you don't have in a clinical trial, is some people switched from the novel substances to psilocybin, or from LSD to psilocybin, or from psilocybin to LSD. So that was every time one person. We don't have the reason. It can be that they just were not able to acquire it. I think I'm looking at Eileen. We don't have the reasons. No, we don't. So let's go to the first results. So we used the CARS, as I said, to assess ADHD symptoms. It are 30 symptoms, and an example is shown here. I interrupt when others are talking, and then I think, oh, should I do that myself? Not at all. They could rate that on a scale from, I don't know, 0 to 5 or something. Not at all, and very much, very frequently. And this are the things, or this is on the y-axis. You can see the total amount of symptoms represented here, and here you can see the assessment points, baseline, 2 weeks after microdosing, and 4 weeks. And what we show is that they were, and I have to do this. So this, the orange line is the 65 cutoff line, so elevated ADHD symptoms. And this would be then, between those two blue bars, is that you have probably ADHD when you use this survey to assess it. So you see that our sample was well above the 65 cutoff. And after microdosing, they decreased and they went under the cutoff. What is also interesting, I think, because you can say, oh, it's a naturalistic study, you did not include a control group. That is totally true, I know that. But what I do like about our data is that we also had, so in this group, we split it up. You had people using medications alongside their microdosing. And you had people who only microdosed. And for those people who combined the microdosing and the conventional medication, you see that they also decreased, but it went slower, the process. And this was not attributable to the severity of the ADHD. We also asked them about their well-being. We tested that with the WHO 5 well-being index, and this contains of 5 simple items shown here. And they have to say all of the time or at no time. And then you just do the sum score. It's actually from 0 to 100. It's not shown here on the graph. And also here you have a threshold where you say if you're below 50, you really have poor mental well-being or well-being. Here you can see that our sample was really not doing very good, but after microdosing they increased to, I think it's called then moderate well-being, or in a better range. And here you can also see that these groups, so medication use and microdosing, they differ slightly. Then what we also did is we were also interested in behavior, and it's difficult when doing a naturalistic study, but we gave them a computer task. We focused on time perception because people with ADHD have problems with time perception, but also because in another trial, an effect of LSD on time perception was shown. So we asked them to listen to several tones they had several durations. So they were presented with the first tone of 300 hertz. They had to listen to it, and then they heard a second tone of 440 hertz, and they had to reproduce it. So they had to push a space bar, and then just leave it. Don't push it anymore if they thought that this was the interval. The reason why this is a different hertz is that you cannot simply reproduce it from your auditory memory. What is the dependent variable? You do this. Ooh, that's a bit too much. You subtract their reproduction from the original tone, and you divide it by the original tone duration. This is what we showed. Actually, I can be very short on this. We didn't show much. These are the separate intervals, the separate durations. And when you zoom in on one of the durations, you see that there is an effect, and this is the effect. There was an overestimation of this interval only for individuals who used a conventional ADHD medication and microdosing after 2 and 4 weeks. But since it is only on this interval, and you also have to know that there were only 2 trials per tone, we also want to see this reproduced in a more controlled trial, so we're hesitant to draw conclusions from this. So the summary of this part is that in this study we showed improvement in ADHD symptoms after 2 weeks of microdosing, and then also after 4 weeks of microdosing, and that there seemed to be a delay in the decrease in ADHD symptoms when people combined their conventional medication with microdosing. What is interesting, we don't have a control group, but we can compare to norm scores or other studies, and we showed, so the change we showed was also shown in studies that used mindfulness-based cognitive therapy or people who were under treatment with methylphenidate. And something interesting that I will come back to in one of my last slides is that 20% of the sample did not show improvements in ADHD symptoms. So there are people that do not respond. Then the well-being, I showed you increased well-being after microdosing, and these changes in well-being or improvements were related to a decrease in ADHD symptoms. We have to say that we did the study in the Corona period, in the COVID period, and we also compared our scores to the norm scores of a very large study that was conducted in that period too. And they are similar, so similar low well-being. And then I have to look at this after 2. So this shows that our scores are in line with this sample of normal people who were tested in the corona period. This I already addressed. We do not show a lot on the time perception task, and what I also said, there has to be caution because the sample that showed a difference was a very small sample. I think that there were 9 participants or a bit more in this conventional medication combined to microdosing group. So I totally acknowledge that there are limitations to this study, but there are also strengths. We use validated questionnaires, and like I said, you have norm scores to compare our data set with. You have survey studies asking people, hey, how do you feel, or how do you feel when microdosing? What we did is a step further. You ask people before they start to microdose and then follow them up in time, so you can do some causal inferences. And there is, what I do like is the ecological validity. People choose their dose, they choose the substance they want to microdose with, they choose their scheme, they can do the test wherever they want, whenever they want. The limitations are that I showed you that in one of the first slides, we have a large dropout. We don't know why people dropped out. You cannot ask if people do not respond anymore. We don't have a control group, but we're now working on that. We're asking people to take part in this study for a control group. And we also know that it is a self-selected group. People really had the intention to microdose. But I was thinking about that. So people who engage in lab research also have their motivations to engage in lab research. So in that sense, yeah, it is a limitation, but other studies also have their limitations. So like I said, this is a work in process. We're running a controlled study together with Matthias Lichty Group. It's sponsored by MindMed. I hope that we can conclude it this year. I'm looking at Matthias. He's nodding, yes. So hopefully we will be able to present the results of that study soon. So let's zoom out. Talked a lot about what's happening in Maastricht, but things are happening in the world too. What we see is that there are some controlled studies. Oh yeah, I had to change that. It has increased. I think 8 single-dose studies, 4 repeated dose studies, and you can see then that the dosing, like I said in the beginning, people take doses according to schedule. Here you see that in some studies they receive 2 weeks of microdosing, 3 weeks, 6 weeks, and then the doses range. Not all studies use the same LSD, some use base, some use start rate. So it's good if you're working in this microdose range that you have that on your mind. When reading these studies, 5 micrograms of base is, you need a bit more to convert that to tartrate. Psilocybin studies, I'm not sure anymore, I don't think that there are yet really controlled studies. Most of them do it like the self-blinding study by Imperial College, or they ask people to use mushrooms or truffles and then conduct the tasks online or come to the lab. Some studies, what I really like is that they ask for, that they have a sample and that they do then the analysis so that they know how many psilocin or psilocybin was in there. And here you see the details of that. Here it is important that the storing conditions will also influence the content of your psilocybin. What we see is when they give repeated doses or when they take repeated doses, it are 2 doses per week in general. A summary of those, and it's very quick, and it's very short. So what we see is that you have self ratings, you have computer tasks, you even have studies that include imaging, EEG or functional imaging. Some studies show that mood states, positive mood states, negative mood states are increased. Also, some participants show increased attention, creativity. It's a more difficult one. I think one psilocybin study has shown that creativity can be enhanced, but some studies just don't show anything. We showed that people have an increased pain tolerance. So when doing the cold pressure test, they can keep their hand longer in water, cold water. There was a study by the Chicago lab showing changes in brain connectivity, which was positively correlated with changes in mood states. You see a change in oscillations, theta waves, which is theta waves linked to learning and memory. There's one beautiful study by Madsen by the Copenhagen lab that shows that even the tiniest dose of psilocybin also shows receptor binding. They did a PET study. And there is recently a study, it's not yet really published, but it's a pre-published thing. They show that the night after microdosing, the sleep duration is increased. That's also a trajectory we would like to follow to investigate the effects of microdosing on sleep. Then what is shown too, that it's overall well tolerated. People show slightly elevated blood pressure. And what we also showed is when you look at markers, we showed increased BDNF levels after 5 and 20 micrograms of LSD up to, for the 20 micrograms, we showed it up to 6 hours after intake. What you have to remind is that these are all acute effects and mostly single dose studies, mostly LSD studies and healthy volunteers. What we need to know is, what I will also show you in the last slide, is you need to know whether these effects are persistent and whether it helps in patient studies or patients. Oh yeah, I included these. Yeah, I also like to look for case studies, and I found these. Found 2 case studies where people self-administered psilocybin or another psychedelic. I think the other case is also psilocybin. And it helped in the treatment-resistant depression. It was a psychiatrist who assessed with the MADRS the scores, and it really decreased. I think he had a number of rounds with microdosing. Cannot remember the details anymore, but look into it. It's only 1 paper. It's super interesting. And here also another person who had Lyme disease, but then also suffered from depression and anxiety. And then one day also decided to microdose, and this helped a lot with his depression. These are just case studies, but I do think there is value in it. It tells you something that it can help people, but it also links to, oh yeah, one more slide, and then I will show you to what it links. The question is, will it be over-the-counter medicine? Because you can say, oh, non-hallucinogenic, people can take it on their own, ADHD, why not? I doubt that. I would like to have a different approach. And what you also see on the internet is when people now sell microdosing kits, they sell a complete package. This is what they do. They give you coaching, you do journaling, you are really engaged in some kind of therapy. And I do think that is good. When you go to the poster of Eileen, you will see that microdosing also does something with emotion regulation. And people might need assistance when emotional processes are changing too. Here you see a quote of somebody who said, having microdosed often before the last 7 years, I can say that the monitoring, group communication and journaling has a much higher impact than just using it intuitively or even with a strict protocol. I was skeptical of the calibration process, but it did make a difference. What they do is they let people go through a calibration process where they test different doses of psilocybin, and then they can make up for themselves, does it work for me or not, and then move on to the next dose or not. And this is another quote stating, my intention to heal has been accomplished now, which has enabled me to formulate a new intention for going deeper into the process. I also subtly transformed in a pleasant way. All in all, this program has exceeded my expectations for what I can achieve. You can also think, oh, this is promo talk on such a website, can be, but I do think that we have to keep on testing the value of microdosing. And here, yeah, I circled this because intention is also very, important. So, but this also links to frequently mentioned issues. I'm looking at somebody of people who are not that fond of microdosing. So what is mentioned? Yeah, you know, people are breaking blind, and it's due to their breaking blind that they have these positive effects. You can see that in the field, you can see that in the lab, people do sense bodily sensations. And this might cause people to have, if you already have certain expectancies and you break blind, you might steer the results into a certain direction. Another problem is the motivation. Why do people engage in microdosing research, in naturalistic studies? That's also what I also told you. I think the perfect solution, I don't have the perfect solution, but I do think that we have to include, we already do this, including treatment guesses. What we did not do is justification. So ask people, in the example I gave you, we did this dose-finding study. It was a within-subject study, so people received on 75%, 3 of the 4 times they received LSD. If you have to guess then when you receive LSD, you have a higher chance of guessing correctly. So you need to ask for a justification. Why did you say that you think you had LSD? And then they might say, yeah, well, I felt this or this. And I think you can use that then in your analysis in some way. What I do like is another procedure used by the Chicago lab. They tell you can either get an hallucinogen, a stimulant, a cannabinoid, or a sedative. And with this approach, here you can see with the 6.5 micrograms of LSD, they had no correct guesses. With the 13, they had 2 out of 20 correct. With 26, they had 6 out of 20 correct, and placebo, 14 out of 20 correct. It's also not the ideal solution, but it is a solution, and I can also think of other ways to deceive participants, perhaps. And of course, you deblind them, you debrief them then afterwards. I would like to end with this. I already said in the beginning, this is something that lies close to my heart. I really want to look into this more personal factors that determine your effects of microdosing. What should we look into? The age, biological sex, weight, dosing scheme. Why age and biological sex? Because age, because we know that 5-HT2A receptor binding changes with age. Biological sex, because we know that females in research, in LSD research, has shown responses that are a bit delayed compared to men. Oh, there is something missing here. Yeah, what was also an interesting one is how you metabolize the substance. If you're a fast metabolizer, I know that there are not a lot of people, but they might, the substance might not reach the system. Should we also investigate whether there is tolerance after microdosing? Is it true that people have to up-titrate? We have to know about the working mechanisms so that we know which indications could benefit from microdosing. We have to look into the therapy format, and we also have to look into safety. If you're going to look into the literature, you see that some people are concerned about this. But in these articles, you also see that more research is needed, and it's not very sure that this will happen with microdosing. These are the references I've used, and I want to thank you, and I also want to thank the whole team that worked on these projects. Thank you.
Any questions? One question for Kim? Yeah. 1 second, we get you the microphone.
Yes, thank you.
Thanks so much for your talk. I had a question about the splitting into the medicated and unmedicated groups. I was wondering if you also looked at that in terms of the diagnosed and undiagnosed, because I'm just anticipating a criticism, particularly from like psychiatrists, of like, oh, if they're medicated, they have to have a diagnosis, And therefore, is it just that it's two subgroups that are, rather than a pharmacological difference, and maybe the people who are undiagnosed watch a bunch of TikToks and they're suggestible and they're more prone to placebo or something like that?
Yeah, I think we had more people who were microdosed than people, and I'm looking at Eileen, that were not diagnosed, right? We did not look into, no. So the people were grouped, everybody was tested on the cars, also the people who were diagnosed. And I hear your criticism, but yeah.
My anticipated criticism, not my criticism.
No, but it is a valid point, but I also think, and we hear that more, that not all people who are diagnosed are correctly diagnosed. So I think it's a fair process to have them all do the CARs. But I also hear you that these diagnosed people were the ones who were taking the ADHD medication. Yeah, I cannot give you a good answer to that. We did correct for comorbidity, and that did not change the data. And we also corrected for something else. Medication use, that did not change the data. Yeah.
Thank you.
Thank you.
Thanks once again, Kim.